não aparece, fica falando que tem alguma coisa errada. Será porque eu tô com vários abertos aqui do YouTube? Talvez eu tenha que fechar?
Passa pra mim, consegue compartilhar a sua tela? Deixa eu dar uma olhada. Já tá ao vivo já.
Não, sim, mas aqui o chat.
Ah, é o chat já. Apesar como você tá na conta do... Como você tá na conta do... Da S.I.N? Como você está na conta da S.I.N, entra no YouTube através daquele link que você compartilhou. Aí você escrevendo lá como você está dentro da sua própria conta aí nesse computador mesmo. Vai lá naquela no WhatsApp, clica naquele link que você compartilhou da transmissão. Aí vai estar o checkzinho embaixo, do lado. E o que você digitar é assim que está escrevendo. Você também não tem problema, pode escrever aí.
Ah, não, aqui tá como tá o meu nome aqui, ó, D, ó.
Troca só clica em cima e troca pelo... Pode clicar aí no ao vivo.
Deixa eu trocar aqui também, às vezes é isso.
Não porque do lado ali do teatro tá o logo da S.I.N. Eu não sei porque o teu não carregou o chat. Fica lá em cima.
Será que tá no da S.I.N? Porque, ó, aqui no Google, aqui em cima tá o meu ainda.
Não, mas ali do lado tá... No próprio YouTube já tá o logo da S.I.N. Vai sair assim mesmo. Ali em cima não tem problema. Pode ver que até agora o ícone já saiu da S.I.N.
Tá. Eu tinha passado isso daqui pra inglês. Ah, saiu mesmo. Passando aqui pra eu mandar pro pessoal assistir.
Até agora só tem eu conectado.
Aqui, deixa eu parar de compartilhar a tela, que eu acho que já lá entrou. Tô mandando pro pessoal aqui pra ver quem consegue entrar. Compartilhei com a galera, eu acho que deve começar algumas pessoas a entrar.
mandando mensagem. Eu tô aqui, o teu chat não tá vivo. Dá pra acompanhar ali também.
É, aqui aparece espectadores simultâneos, aparece um só.
É eu.
Eu não sei como que foi essa divulgação desse curso dela.
Então, eu achei estranho, como tá marcado para 10 horas por dia. Não tem nada de divulgação. O pessoal tá aguardando por 10 horas.
Meu Deus. Agora tá parecendo que tem 6 pessoas esperando.
Quantas?
6. O interfone da todo mundo. Meu Deus do céu.
Ela não mandou nenhuma mensagem pra você?
Andou falando que o filho dela caiu na escola. Mas já me conecto. Tá entrando, ela falou.
Colocar lá no chat, né? 10 minutinhos, 10 minutinhos, na aula.
Verdade, claro. Vamos.
Só pra segurar o pessoal que tá aguardando.
Vamos começar em 10 minutos. Uai, você tava entrando?
Ainda não.
Eu só vou explicar pra ela, pra compartilhar dela.
Na realidade só vou a explicação que a gente tem que dar pra ela. Como ela vai começar a aula, como ela vai ensinar a aula. Se ela souber compartilhar dela melhor. Agora eu vou explicar pra ela. Se ela recebeu o defeito na comunicação.
Esse efeito pode ser esse que eu te mandei, vou mandar pra ela, por exemplo.
Não, esse que você mandou pra mim é só é o banner dela. Eu não tenho esse efeito. Esse efeito é o Johnny que compartilha com os doutores. Aí você vai aí
Tá saindo som, a Laís falou, no geral.
Oi, bom dia.
Oi, Débora, tudo bem? Bom dia.
Bom dia, tudo bem?
Peço desculpas, mas já tudo solucionado aqui.
Espero que esteja tudo bem com seu filho.
Tá tudo bem. Nada, graças a Deus, nada muito complicado. Já conseguimos arrumar tudo.
Ai, que bom. Deixa eu ver. Doutora, recebeu um fundo de tela ou não?
Não recebi.
Deixa eu ver.
Eu estou na oficina da escola.
Doutora, você está me compartilhando dela, doutora?
Sim, agora estou abrindo a minha apresentação e já vou compartilhando.
Ok. Por enquanto, a gente já está online, mas está só uma imagem lá com uma musiquinha, ok? Quando for iniciar a transmissão, a Débora vai sair, eu vou sair, né? Aí vai ficar só a doutora. Aí a doutora, se a doutora quiser acompanhar a transmissão por um celular, pode colocar no YouTube ali e ficar acompanhando. Porque, assim, vai ficar um tempo aquela sua imagem que nós temos um pequeno delay, né? De transmissão. Então, quando a doutora visualizar a sua imagem ali, quando estiver você mesmo aparecendo, aí já pode iniciar a aula.
Tá certo. Então eu abro o meu celular com esse mesmo link, é certo?
Isso, com o link do YouTube.
Tá certo. O link do YouTube que foi encaminhado para os participantes.
Sim, esse é só para utilizar como acompanhamento.
Tá certo. Aqui, só um pouquinho, para compartilhar, eu coloco aqui tela completa, certo?
Isso, seria legal você colocar aqui a tela com a doutora no cantinho.
Tá no cantinho, eu só não estou achando compartilhar. Verdade, só aonde que não estou achando a função
Pode clicar da janela. Clica na janela. Compartilhar a janela.
Apresentar, é isso.
Eu já compartilhar bem aqui no teste.
Pantalla completa, ventana, compartir. Sim.
Isso, assim mesmo. Tá ótimo.
Assim tá ótimo, mas a minha apresentação, deixa eu ver se sai ou não. Você vê a minha apresentação?
Não, tá.
Não.
Tem que. Não. Na ventana tem que selecionar lá a apresentação da apresentação em PowerPoint?
Tá em Keynote. Mas eu entrei ali nos 3 pontinhos.
Sim.
Aí tem trocar de desenho, tela completa, tela parcial, mas eu não acho aonde compartilhar a minha apresentação.
O layout está ok, não tem problema. Pode manter aqui o layout.
Sim.
Na apresentação tem um quadradinho com uma seta dentro para selecionar a apresentação. Aí onde está o micrófono lá.
Sim, tem microfone, câmara, CC, uma cara, um rosto, uma sorrisa, apresentar. Apresentar, mas ali só sai.
Quando você em
ventana aqui. Aí sai. Vou colocar em grande e aí você vê. Sim? Então está a minha apresentação. Eu vou colocar em silêncio. Você está me ouvindo?
Sim, estou ouvindo. Só um minutinho.
Tá certo. Eu já coloquei no YouTube também.
Tá ok. Pronto. Doutora, no geral aqui já estamos prontos para começar. Débora, você conseguiu o fundo?
Não, vamos sem mesmo.
Vamos sem fundo então. Ok, então.
Tá certo.
Doutora, então já está com o seu link já no YouTube, já está conectado no celular, né?
Tá certo.
Ok. Então, vai começar aqui, doutora. Quando for começar, Aguarda aparecer até a sua imagem mais a sua apresentação e pode começar a aula.
Tá certo.
E quando for finalizar a aula, na apresentação tem alguma coisa de fim, alguma coisa de finalizando, no fim da apresentação?
Não, é só um último slide me despedindo. Só isso.
O que foi, Débora, que você mandou aqui pra mim?
Não, o nosso áudio estava saindo na transmissão.
Hello, dear colleagues. This is Dr. Patricia Fretes from Asunción, Paraguay. I am showing you a beautiful view of my city, Asunción, and I want to start this conversation about how to select the right abutment to complete our treatment with the implants. So, a very important topic that I want to share with you is how to choose the gingival height. That is a very important subject because we know that we have many heights of that part of our abutment, and sometimes we can cause some damage in the periosteum or in the bone around our components. Just a second, because I want to change the slide, and right now it's not working properly. So, as I was telling you, to choose the right component, to choose the right abutment, starts with the choosing of the gingival height. O sea, es que no está funcionando. Okay, right. So, Deborah, if you can just check, I changed my slide. But I'm looking in the YouTube, but I am not seeing that is moving. Okay, now it's recording, I guess. Now it's working. Okay, so this part is so important to begin our treatment of rehabilitation of our implants. Because as I was saying, to choose the right height of any component is so important step. Here we have our Conmorse implant placed in bone. And now, as you can see, a probe to measure the height of our soft tissue. Why is this so important? Because nowadays we know that we have to try to work the prosthesis as high as possible to the gingival margin. So this is a very easy way to measure how deep is our implant and how much soft tissue we have. That is to select the right gingival height of any implant abutment. So here, for example, we have 5 millimeters height from the platform of our implant till the superficial margin of our soft tissue. It's such an easy way to measure it, but we also have a very nice way to measure that soft tissue. This is a collaboration of a very good friend of mine, Dr. Gabriel Villalba, who selected those provisional abutments just to measure the gingival height and to know where is that chamfer of our component placed. The ideal is that the chamfer of our abutment will stay 1 millimeter till 2 millimeter deeper respect to our gingival margin. If we can respect that, we will have very good results. So here, for example, we see this kit with the provisional abutments, and we see that we have the height of 1, 2, 3, 4, or we can also select 1.5, 2.5, 3.5, 4.5 components. And in this way, we can measure our gingival margin so easily, and we can select our abutment easily too. So we can do this also with UCLA abutments. For example, in this image, we see an abutment placed 1 to 2 millimeters away from the gingival margin, especially when we are working with cemented crowns. It's so important because we know that one of the reasons of complications can lead us to failure. And one of those complications will be, for example, the cement that we can't control when it's going inside. And if this chamfer of our abutment is too deep, we can lead to those failures. So here, for example, in the S.I.N line for cemented abutments, we see that we have many heights of that gingival height. For example, we have 0.8, 1.5, 2.5, 3.5, and it is depending on how deep we placed our implant, or it is also related about the thickness of our soft tissue. So we have so many heights to work properly. We just have to know how to select this gingival height. And in this example, you can see that the chamfer of our abutment is too deep. You can see that that chamfer is contacting with the periosteum. And we know that periosteum is a tissue that hurts. Sometimes when we wrongly select our abutment, we can hear from our patient that he's or she is feeling a lot of pain. Perhaps it can be because we selected the gingival height wrong. We didn't use the probe, or we didn't use that selection kit to measure how far we are from the periosteum, how far we are from the gingival margin. So this is a very special point that we have to look at from the beginning. That's why I'm talking about this in the beginning of my presentation. And here we see a draw of a crown that is placed so deep, almost in contact with our periosteum. So we can have problems of bone losing, pain, hearing that from our patients. And here again, we see that the chamfer of our abutment is placed in a right height, away 1 to 2 millimeters from the gingival margin. So this is very important to talk from the beginning. What can we say about selection of abutments for our rehabs? We have so many options, and we are going to talk about each of those. I am starting with UCLA. We have this component that we know that will suffer deformation because it's going to be work in the laboratory under very high temperatures. So we know it's not the best option to do our prosthetical treatment, but sometimes we have to use those. And for example, when we don't have a right height of gingiva, or our implant is not good angled, we can use this option. But just to remember why this is not the best component. Here you can see a micro image showing that gap between the implant platform and our UCLA that we know that is going to suffer deformation because it's worked in the lab under a lot of temperature. So it's not our first choice. What about when we have to rehab a single crown? Which are the options for those single crowns? Which abutments we have available to choose and to work with? Okay, we have to know if our option is to work with cemented crown or it's going to be screw. If we are going to work or to select an abutment to work with cemented, we have to choose first the gingival height. And we know now how to do that. Second, that we have to choose is the abutment height, where we are going to place our crown. And in S.I.N line and in many lines of other implant systems, we used to have two heights of the abutment. We have in S.I.N 6 millimeters and 4 millimeters. And as you can see in the image, we also have two diameters. So it depends on the space that we can work. And we also have the anglet one. We just have to remember that the anglet has a part that we have to cover with soft tissue. So when we are using those abutments, we need more soft tissue to cover that elbow. I always say that it's an elbow. And this system, this abutment, uses a self-implant impression tray. As you can see, the blue one. And this is for 6 millimeters height of our abutment, or for 4 millimeters is the yellow one. So here we can see two of those abutments that are for cemented crown. I really love to work with the screws. I prefer to work with the abutments with the screws. But we also have one body abutments for cemented crown, as you can see here below. And of course, if we want to work with a screw prosthesis, our option will be the UCLA. And here we know that if we work with UCLA, we have to make our impression direct on the implant with this transparent that is direct on the implant. And we have to use the proper analog. That will be different with the, they are saying that the image is not changing. Thank you, Dr. Carlos. Image is not changing. Can we solve this? And And if, Dr. Carlos, can you tell me if the image is changing now or not? Dr. Carlos? I was talking about the cemented. I will solve this. Just a second. Deborah, if you can tell me, please. I close my presentation and now I open it again. Let me check if Dr. Carlos or someone can tell me if the image changed now. Dr. Plowman, image is not changing. Not now. Okay, I will stop this. Just a second. Thanks for the patience. We will solve this problem. Presentación, a ver, vos sabes cómo se puede, ¿entendés esto del Meet? Para poder compartir la presentación, sería acá, no, ¿verdad? No. Sí, chatear, personas, detallar la reunión, actividades. Acá, presentar. Sí, adelante. Ventana. Here. Is it possible to see right now? Maybe. You can see in a small image. Sometimes it works like this. What about now? Is it possible to see a small window with some images? I think we have to stay like this. Okay, no modo, I will, okay. Please, if you don't follow me, let me know. Now, yes? Thanks for telling me, Dr. Plowman and Dr. Carlos. Can you see now the abutments? Yeah? Okay. We will continue then. In the first line above, we have the abutments, straight abutments and angled abutments with the screw. Those are my favorite. And below, we have one body abutment. I always prefer to use the screwed ones. And those abutments are to work with cemented crown. We were talking that we have to select gingival height, and we also have to select the abutment height. And in S.I.N line, we have 6 millimeters and 4 millimeters. And we have to select if it's going to be straight or it's going to be angled. If we are going to work with angled, we should know that we need more gingiva to cover that angulation that I call elbow. And the other option for single crowns will be the UCLA, because sometimes we want to work screw without cement. And we have to do the impression over the implant straight away. Another option is to do cemented screwed crowns, but those we can do with the Duotech line, with the digital abutments. And we can leave those as screwed, but firstly, we have to cement those. And we also have to choose the right analog. If we are going to work straight on the implant, we are going to use the analog of the implant. But if we are going to choose to work with one of those abutments that I show you, the straight of the or the angled for cemented, we have to choose their own analog. So we have another option. If we are going to work straight off their implant, that we say that we can select the UCLA, but I also really prefer to work with this component. We call this the conical abutment. So this is an abutment that we have to place inside the implant, and then we will start working above the chamfer, and our crown will be screwed. That's why I really love to work with this conical abutment. What's the problem? The only problem is that we need at least 7 millimeters height to place our crown using this conical abutment. And we have to know that the diameter of our chamfer is 4.8. If we have a space enough, this is my favorite component. Dr. Carlos, Dr. Plamen, are you seeing the conical abutment with this impression tray? I just want to be sure that you are seeing the changes of my slides. Okay, so now we have that this conical abutment has a specific transferent for itself. And it's so interesting because we can use that conical abutment with single crowns, with bridges, with protocols. We can choose that conical abutment. So just to remember that we can work direct over implant when we are going to select the UCLA, but we know it's not our first choice because of deformation that we know is going to suffer because of high temperatures. And another option to work or with single crowns or with multiple crowns is the conical abutment. This is really my favorite. Another option is this one body abutment that is the multifunctional abutment. But if you ask me which one is my favorite, of course, is the one with the screw. Always remember that both of those components have 4.8 diameter. So it's a wide component, a wide abutment. But we have something really interesting that S.I.N. offered to us. That is this micro mini abutment. That is only 3.5, because sometimes our main problem is the space or the thickness of our gingiva. So sometimes we can't use this 4.8 diameter of our chamfer. So this is a very interesting option that we have, this micro mini abutment. And for multiple united crowns, we have also the mini abutment. And we have the angle mini abutment that is 17 or 30 degrees. So remember that those components, that those abutments are all 4.8 wide in that part. And talking about the conical abutment, can you see, Dr. Carlos and Dr. Plum, can you see the change and above conical abutment, just to be sure that is changing? So this is a very nice option for screw prosthesis and also for single crowns. But we have to be careful selecting the following components, because this conical abutment is to be used for single crowns or for splinted. And if we are going to work with single crowns, we have, again, it's not changing. I'm so sorry. Let me go back. Let me go back with this. Let me check. Is it possible to see now my presentation, Deborah, like this? like in a small window, or I go to full screen again. Okay. Is it possible to see in a small window? Now I'm just sharing a small window with the images of the single crown abutments and with the title above conical abutments. So Dr. Carlos is telling is okay. With this small window, maybe we can, okay. I will show like this, okay? It will work better. Okay. I was telling you that we have this abutment that I really love, is conical abutment, that we can use it for single crowns or splinted. When we are going to work with single crowns, we have to be sure to ask to our dental provider that we want transparent, anti-rotational, and decalcinable abutment. Hello? So this is a very important subject that we have to ask to our dental provider. Everything must be anti-rotational. The transparent, the coping that must go to the lab must be anti-rotational. And if we are going to work with a splinted, it's different. If we are going to work with a splinted, we have to ask transparent and the coping rotational, because we are going to splint many crowns, right? So that is the only point that we have to consider when we are going to work with the conical abutment. And this will be the procedure of the lab to make the structure, right? So it's rotational. They are going to work on the structure of our prosthesis. Another option that we have for our rehab will be the angle mini abutment. And we have some characteristic that helps us a lot right now, that is the index. Because in the past, we had the angle mini abutments without those indexes. And by chance, if we had the loosening of the screw, we couldn't find the same position anymore to place our prosthesis above this component. It was so hard to find the same place because it was 100% rotational. But now with this index, we have just 6 possible positions. And we also have 2 options of angulations. Okay, this is available for us, but for United States, I know there are more angled abutments. But for us here in South America, I believe in your area, in your region too, we have the angulation of 17 and 30 degrees. And this is an abutment with 2 screws. We have a screw to place our abutment, and we have a second screw to place the prosthesis. And above the image, I know you can appreciate that is protector for our abutment. So this is something very important. This is an image that we made with my dear friend from Brazil, Dr. Luis Nantes. As much angulation we choose, we need more soft tissue to cover. This is very important because, of course, the patient doesn't want to see that metallic part. Being this yellow or being this pink, the patient doesn't want to see that metallic part of our abutment. So we have to be aware that if we have, for example, selected an abutment with the height of 3.5, we need at least 5.96 millimeters of soft tissue to cover that angulation, that elbow that we were mentioning about those angled implants. And for example, if we select an abutment of 3.5 with the angulation of 17 degrees, we need at least 5 millimeters soft tissue gingiva to cover that part. Most of the times, the angulation will be shown in the buccal part. So we have to cover this. And it's an important image to keep, to select our abutment in advance. Other ways is to test it in the implant in the mouth of our patient, but knowing this detail, you will be aware to select it in advance. And for external hexagons, I'm just showing an example that we can combine, for example, the straight mini abutment with the angled one. Because what are we looking for when we are working with the angled abutments? We are looking for parallelism. We are looking to place our prosthesis parallel. And that's why sometimes we combine straight with angles, or we only use angle, or we only use straight. That is the best of the situations, but sometimes we can't. So as you see, we are placing this straight mini abutment. We are going to give a torque of 20. And now what are we going to do? We are looking for that parallelism between the two implants with the abutments. See why? To have 1x of insertion of our prosthesis. That is very important for passivity. So that is what we are looking for with those angled abutments. As you see, that is a transporter that will show us in compared to the other one if they are parallel. So there is a small trick that we used to use when we are working with the anglet. As you see, we have to do a small reverse 2 times to let the screw, this tool, to place the screw of our mini abutment. And now we have placed both with the same insertion X. That is going to provide us passivity of our prosthesis. So here in this image, let me make it bigger to show you better. This is the sequence of working with those intermediaries, with the mini abutments, being those straight or angled. I want to mention to you something. If we are working with external hexagon, if we are going with internal, if we are working with Morse connection, the chamfer of our mini abutment will be the same. The only part that we have to select right is the inner connection of our abutment. What does it mean? If I'm working with external, I should ask the dental provider to send us the proper one for external. Same with internal. Same with Morse connection. And here we have to be aware of something. Yeah, I can make it bigger, Dr. Lamen, just a second. I will move it a little while I'm talking. So, I am mentioning that those abutments above the chamfer are the same for Morse, for internal, for external, or all the same. But what we have to choose rightly is the prosthetical connection. Okay, I will make it bigger again. Just a second. Just a second. Okay. I will show a big one again, and please tell me if it's not. Can you see now bigger? Is it possible to see bigger or not? Okay, sometimes technology helps or not. So Let me see if I am, if it's possible. Is it possible to see, right or not? No, okay. Yes, I'm doing reproduction. Doctor is saying that is okay. Just a second. Let me try to. Is it showing bigger? I think not. It's just in a window, right? Just let me try to solve this issue. Talla completa. Now not. Let me try to window, select. Let me, okay. Now it will be showing. Now you can see in big, right? Now is it possible for you? It's okay. It's okay now. I click to make it bigger. Yes, okay. So what is the good point to have to work in the same chamfer, even if it's external or Morse or internal, is that we can use the same transfer, we can use the same analog, we can use the same cylinder for the lab, we can use all the same. What we have to select right is the prosthetical connection. We have to choose between external, internal, or Morse. If we are talking about Morse, we know that the inner part of, for example, SW strong is 16 degrees, from Unitight or EpiCut is 11.5, and for example, from the compact implants is 5 degrees. So that is the point that we have to choose rightly. But above, when we are working, is the same. We use the same transfer, the same analog, and the same cylinder for lab. Can you see an image of two mini abutments? Is it possible to see a big image of two mini abutments, just to be sure that the image is changing? So here we have an image of two mini abutments placed below the gingival margin, 1 to 2 millimeters. That is the perfect situation. Another perfect situation is that we have the implant separated to place those wide mini abutments that we know we need 4.8 millimeters for each. So it's very important to consider how separated are our implants to select those mini abutments, because those are wide components. Always remember that we need more than 5 millimeters to place one far from another. And those mini abutments are only indicated for splinted prosthesis. It's not for unitary, not for single crowns, because it's totally rotational. So you see there two crowns splinted between each other. Another option, very interesting one, are the micro mini abutments. I was showing to you the images before, so you can see that the chamfer of those abutments are 3.5. For external, we have for Morse, we have for 16 degrees, 11.5 inner part of our Morse connection, and also for the line slim of Unitide, the implant that is 2.9 diameter. We also have those micro mini abutments. For those micro mini abutments, of course, we need other transfer trays, and we need other analogs because those are smaller. And also we need the lab prosthetical components in that same diameter. And here we see an example. If you can tell me if you can see two micro mini abutments, those are placed very close to each other, but we don't need 5 millimeters. We don't have 4.8 millimeters of our platform, of our chamfer. We only have 3.5. So in situations that our implants are placed close to each other, we can select those abutments to finish our prosthetical treatment. Those are very useful. Those are very useful abutments. And here you can see a splinted prosthesis using those micro mini abutments. But a very important information, we can also use this micro mini abutment to place a single crown. The only thing that I have to remind you is that we need everything anti-rotational. What is everything? The impression tray, the cylinder for the lab, and our analog. Those must be anti-rotational, so we can work with single crowns with this micro mini abutment. So here we have this situation. We selected those abutments for cemented, and I prefer to work with the screwed ones. Here, just to show you, remind you what we were talking at the beginning, that we have to select two heights. We should select first the gingival height, and we have to select the abutment height. How to select those? The first one, the gingival height, we can use a periodontal probe, and we have to consider to leave the chamfer 1 to 2 millimeters under the soft tissue. And to select our abutment, it will depend on the space between the antagonist and the margin of our gingiva. If we have more space, if, for example, we have 8 millimeters, 10 millimeters, of course, we can select the taller one, because the taller one will be more retentive. But if not, we will select the shorter one, the fourth one. I want to share with you some cases. Please let me know if you can see the patient smile there, so I can continue with my talking. Is it possible to see soft tissue? Okay. This is a case where we started working with provisional. We did 2 soft tissue procedures to better the gingival margin around. And you can see there, again, is trapped. I was clicking, but I think I will show you again in small. Let me show. Is it possible to see in a small? Is it possible to see in a small, people? Because I was passing the slides, but they were communicating me that it was not showing. Okay, now it's okay. So here I'm showing to you, I'm sharing with you a case where I started to work with the conical abutment. I really love this abutment, but we were saying that we need at least 7 millimeters to place the crown. We were working at the beginning with soft tissue management. 2 times we did soft tissue management procedure to reach to this situation. And then we did a conventional impression, Remember, it's going to be a single crown, so we are selecting anti-rotational transferent. And here we have our model from the lab. It's not showing, or is showing, yeah. Now we see that the lab prepared a model where he's going to work the crown. And here we have the final result of our ceramic crown. And we can see a very nice soft tissue contour working with the conical abutment. So what do we have to know if we are going to select this component, the conical abutment? We should know that we need at least 7 millimeters space for our crown. And we know that there is an advantage with this abutment. We can place a screw crown. And of course, when we are working with intermediaries, like the conical abutment, we are going to dissipate forces. So it is an abutment that has a great resistance to fracture. And we also have to remind that once that we select this abutment, we should torque it and leave it inside the mouth before doing the impression. And this abutment is going to remain till the placement of the crown. We can place above this abutment a protector, or we can make a provisional crown, or if we have our digital lab in the clinic, we can make the crown in the same appointment. Another case is a guided surgery where we are going to place a unitide implant, and sometimes we can do these personalized abutments to have more aesthetic in compared to the other piece that is next. So we can ask the lab to personalize our abutment. This is a cemented abutment, and we are going to cement this aesthetical part, and then we are going to place the crown. So we can reach to very nice results. You can see there the radiographical image of our implant placed, the right selection of the gingival height, not so close to our periosteum, and the health of our soft tissue around this crown. So another case, immediate placement of the prosthesis. We can see here the implant placed, also the abutments, the mini abutments, a straight mini abutment placed. Here we see the model of the lab to work with the prosthesis. And here we can see the final result of our work. And here the smile of the happy patient too. Going back, talking about our abutments, we can remind that we have so many options. The most popular is the mini abutment. We only have to remember that we need a lot of space between one and other implant, because this is a wide component. The chamfer diameter is 4.8. Those are only indicated for splinted. And this is sometimes a situation that we face because we respect the 7 millimeters between center and center of implant. We place the implant right, but it's not enough separation between each other to use the 4.5 component or abutment. So if we face this situation, we can easily solve it combining it with the 3.5 abutment, that is the micro mini abutment. So we can combine one mini abutment with one micro mini abutment. Else, if we don't have space to combine mini abutment with micro mini abutment, we can use both micro-mini abutments. But remember that micro-mini abutment is possible to use for splinted prosthesis and also is indicated for single crowns. The mini abutments not. The mini abutments are only indicated for splinted. We can also combine the multifunctional abutment with a mini abutment or with micro mini abutment. And here another situation and good news too. When we place the compact implant, nowadays, we have the possibility to rehabilitate it with a screw prosthesis. Before, we only had the option of the cemented abutment for the compact implants. But nowadays, we can also select the multifunctional and we can place a screw prosthesis. We can also combine if we place, for example, a compact implant with an epicut, I can combine the components, rotational ones with each other. But nowadays, I can rehab those implants, the slim one, the 2.9 with micro mini abutment for single crown screwed one, or I can also rehab the compact with a screw crown, if I prefer, with this multifunctional abutment. And as you see, for example, you place it a strong implant long back, but now you prefer to place an epicut. You know that above the chamfer, those abutments are the same. You are going to use the same impression tray. You are going to use the same analog. You are going to use the same copy. So it's possible to combine. And finishing my presentation, I want to give you a tip. And this is something really, really interesting and important, especially for our labs. This is an image to show how to determine the cantilever. This is something that sometimes we leave to the lab, but it's our responsibility to provide the right information to our lab people or to our lab person, because we have to work together to reach to the best results. So sometimes we place the last implant in canine position, for example, and the lab is going to send us a prosthesis, a protocol till third molar. And we are going to have problems with that because we have to remember that the most posterior implant is the one that receives more forces. So we can have the fracture of our cantilever, or we can even have a fracture of our implant. So we have to be careful to give this information to our lab. This rule is called AP rule. And how do we apply this information? We should mark a line in the most frontal part of the frontal implant. So vestibular buccal to this frontal implant, we will mark a line. And we will mark another line, and those we can do in the model after doing the impression of our abutments. We have to mark another line uniting the most posterior implants in their distal part. So that first line of our buccal implant is going to give us some millimeters of our distance with the other line that we determine in the distal part of our posterior implants. In this case, this frontal line and this back line are 12 millimeters away from each other. These 12 millimeters are variable because we could place the implants more posterior, so we would have more millimeters, or not. Or we could place those more anterior, we will have less millimeters. So this distance is variable. But there is a fixed cipher that is 1.5. So we have to, the distance between the frontal line and the posterior line is 8, and this is the variable. And these 8 millimeters, we have to multiply by 1.5. 1.5 is the fixed cipher. So 8 millimeters, that is the anterior-posterior separation or distance, we will multiply by 1.5. And that is going to give us 12 millimeters. 12 millimeters is what we can extend our cantilever. So our prosthesis won't work biomechanically wrong. So we just have to remember 1.5, that is a fixed distance, and we have to remember that we have to make 2 lines, one in the frontal implant, their buccal surface, and another line uniting the most posterior implants in their distal part. That will give us some millimeters, a distance that is variable. And that variable distance we have to multiply by 1.5. So that is the way how to determine how far we can go back with our prosthesis, not to make it suffer. So, my dear friends, it was my presentation. I really hope that you could get something useful from this. I am always available to share knowledge with you, to share friendship. Here you have the details of my social media. I really appreciate the opportunity that S.I.N is giving to me to show a little of my work. I'm working with S.I.N for 19 years this year, and I'm really happy with their products. And I really appreciate your presence, watching this material, this presentation. So if you have any question or I can help you in anything about related to this subject, please contact me, that I will be so happy to share more with you.